20 minutes after Mrs. Morrison was wheeled into the cardiac catheterization lab, the emergency department's red phone rang with an urgency that made Sarah's stomach drop. Dr. Ahmed answered, and she could see his face pale as he listened to the voice on the other end. "Sarah," he called out, "they need you in the cath lab immediately. Bring the crash cart." Sarah's heart raced as she grabbed the emergency equipment and ran through the hospital corridors toward the cardiac catheterization laboratory. Tyler had been moved to a regular room for observation of his rib injuries, but Sarah's mind was entirely focused on his mother as she rushed through the automatic doors. The cath lab was a controlled chaos of medical activity. Mrs. Morrison lay on the procedure table with multiple 4-lines, monitoring equipment, and the large imaging machinery that allowed Dr. Patel to visualize her coronary arteries. But something had gone wrong, terribly wrong. "What happened?" Sarah asked as she arrived with the crash cart. Dr. Patel looked up from the monitors, his face grim. "The main artery wasn't just blocked, it was completely ruptured. We've got a massive pericardial effusion and she's going into cardiac tamponade. Her heart is being compressed by blood accumulating around it." Sarah understood immediately. Cardiac tamponade was one of the most dangerous cardiac emergencies. Blood or fluid around the heart prevented it from filling properly, essentially strangling the organ from the outside. Without immediate intervention, Mrs. Morrison would die within minutes. "We need to do an emergency pericardiocentesis," Dr. Patel continued. "But we can't get her stable enough to transfer to surgery. The anesthesiologist is tied up with the trauma surgery that's still ongoing." The nurse practitioner who normally assisted in the cath lab looked overwhelmed. Mrs. Morrison's blood pressure was dropping rapidly despite maximum doses of multiple vasopressor medications. Her heart rhythm was becoming increasingly erratic as the pressure around her heart built up. "Sarah," Dr. Patel said, "I know this is beyond your normal scope, but you've been managing her care better than anyone tonight. I need an experienced set of hands to assist with this procedure. Are you willing?" Sarah looked at Mrs. Morrison, who was barely conscious, and thought about Tyler waiting upstairs, probably staring at the ceiling and wondering if his mother would survive. She thought about the promise she had made to both of them, and about all the training she had received in emergency procedures. "Tell me what you need me to do." Dr. Patel began setting up for the pericardiocentesis, a procedure where a needle would be inserted into the space around Mrs. Morrison's heart to drain the blood that was compressing it. It was delicate, dangerous, and typically done only by experienced cardiologists. "I need you to monitor her vital signs constantly and be ready to start CPR if she arrests. Also, I'll need you to assist with the ultrasound guidance and hand me equipment as I request it." Sarah positioned herself at Mrs. Morrison's head, where she could watch all the monitors while staying ready to assist. Mrs. Morrison's eyes opened weakly, and she seemed to recognize Sarah despite her critical condition. "Tyler?" she whispered. "Tyler is safe," Sarah assured her. "He's asking about you. We're going to fix this so you can see him again. Dr. Patel prepared the pericardiocentesis kit while explaining what he was doing. The ultrasound shows about 300 milliliters of blood compressing her heart. "I'm going to insert the needle just below the sternum and advance it toward the heart while watching on ultrasound." Sarah had seen this procedure once during nursing school, but never under such dire circumstances. Mrs. Morrison's blood pressure was now 60/30, barely enough to maintain consciousness. Her heart rate had climbed to 140 beats per minute as her body desperately tried to compensate for the failing cardiac output. "Starting the procedure now," Dr. Patel announced. "Sarah, watch those monitors like a hawk. If she arrests, we'll have to do CPR while I finish the drainage." The needle went in slowly, guided by ultrasound imaging. Sarah watched Mrs. Morrison's face for signs of pain or distress while simultaneously monitoring the cardiac rhythm, blood pressure, and oxygen saturation. The room was silent except for the beeping of monitors and the quiet instructions Dr. Patel gave as he advanced the needle millimeter by millimeter. "There," he said suddenly. "I'm in the pericardial space." Dark blood began flowing through the needle into a collection bag. As each milliliter drained away, Mrs. Morrison's blood pressure began to improve slightly. Her heart, no longer compressed by the accumulated blood, could begin to fill and pump more effectively. "Blood pressure coming up," Sarah reported. 75/45 and rising. Mrs. Morrison's eyes became more alert, and her breathing became less labored. The procedure was working, but Dr. Patel's expression remained serious. "We've drained about 200 milliliters, but there's still more bleeding. The artery rupture isn't sealed. We need to get her to surgery immediately for emergency repair." Sarah knew that meant Mrs. Morrison would need open-heart surgery to repair the damaged coronary artery, a massive operation with significant risks, especially for someone who had already suffered a heart attack and cardiac tamponade. "The OR is still occupied with the trauma surgery," Sarah said, thinking quickly. "What if we can't get her to surgery fast enough?" Dr. Patel was already on the phone with the surgical team. "We may have to do the repair here in the cath lab. It's not ideal, but it might be our only option." Mrs. Morrison seemed to understand the gravity of her situation. She reached for Sarah's hand with surprising strength. "If I don't make it, please take care of Tyler. Help him understand that I fought." "You are going to make it," Sarah said firmly. "But Tyler is going to need his mother to be strong right now. Can you be strong for him?" Mrs. Morrison nodded weakly just as the surgical team burst through the doors. Dr. Williams, the chief of cardiac surgery, had finished the trauma case and was now available to help. His presence immediately changed the energy in the room. "What's the situation?" he asked, quickly reviewing Mrs. Morrison's condition. Dr. Patel explained the coronary artery rupture and the emergency pericardiocentesis. Dr. Williams examined the imaging studies and made a rapid decision. "We're taking her to surgery now. The OR is being prepped as we speak." He looked at Sarah. "You've done excellent work keeping her stable. I want you to accompany us to the OR and continue monitoring during the transport." Sarah had never been asked to assist with a transport to cardiac surgery. It was a recognition of her performance under pressure, but it also meant taking on even more responsibility. As they prepared to move Mrs. Morrison, Sarah thought about the trust that had been placed in her throughout this emergency. The transport to the operating room was tense. Mrs. Morrison's condition remained precarious, and any sudden movement or change could trigger another cardiac emergency. Sarah monitored every vital sign while the team moved quickly through the hospital corridors. "Sarah," Mrs. Morrison whispered as they entered the elevator, "tell Tyler I love him." "You'll tell him yourself when you wake up from surgery," Sarah replied, but she made a mental note of the message, just in case. As they reached the operating room, Sarah realized that her shift was supposed to have ended an hour ago. She had been so focused on Mrs. Morrison's care that she hadn't even noticed the time passing. But there was no question of leaving now, she would stay as long as she was needed. Dr. Williams paused before entering the OR. "Sarah, what you've done tonight has been exceptional. Patient advocacy, clinical skills, decision-making under pressure, these are the qualities that define great nurses." Sarah felt a surge of pride, but her focus remained on Mrs. Morrison. "Is she going to survive the surgery?" Dr. Williams was honest. "It's going to be touch and go. The coronary artery damage is extensive, and she's already been through tremendous stress. But, thanks to your care in the ED and the cath lab, she has a fighting chance." As the OR doors closed behind Mrs. Morrison, Sarah finally allowed herself a moment to breathe. She had just participated in saving a life using skills she had never imagined she would need so early in her career. But the night wasn't over yet. Tyler was still waiting for news about his mother, and Sarah knew that part of her job was helping families navigate the most difficult moments of their lives. The next few hours would determine whether Mrs. Morrison would survive, and whether Sarah's promise to Tyler would be kept. Sarah's training kicked in as she stared at the EKG readout showing Mrs. Morrison's heart in distress. The STEMI protocol ST elevation myocardial infarction required immediate action, but the nearest cardiologist was Dr. Williams, and he was currently in the operating room with the trauma patient from the first ambulance. Mrs. Morrison's oxygen saturation was dropping despite the supplemental oxygen, and her skin was becoming increasingly pale and clammy. Sarah knew that every minute of delay in treating a heart attack meant more heart muscle dying permanently. The golden rule of cardiac care was that time equals muscle, and muscle equals life. "Mrs. Morrison, I'm going to give you some medication to help with the chest pain," Sarah said, her voice steady despite the adrenaline coursing through her system. She prepared a dose of nitroglycerin, checking and double-checking the dosage against Mrs. Morrison's weight and blood pressure. Tyler watched from his bed, his own injuries forgotten in his concern for his mother. "Is she going to be okay? Please tell me she's going to be okay." Sarah administered the nitroglycerin while simultaneously calling the cardiac catheterization lab. She knew the protocol. STEMI patients needed to be in the cath lab within 90 minutes of first medical contact for the best outcomes, but Mrs. Morrison was already showing signs of cardiogenic shock. "This is Sarah Martinez in the ED," she said when the cath lab coordinator answered. "I have a 52-year-old female with anterior STEMI, developing cardiogenic shock. Blood pressure dropping, O2 sat declining. We need immediate activation." The voice on the other end was crisp and professional. "Dr. Williams is in surgery for at least another hour. Dr. Patel is on call but he's 40 minutes out. What's the patient's current status?" Sarah looked at the monitor showing Mrs. Morrison's vital signs, all trending in the wrong direction. BP is now 85/50 and falling. Heart rate 110 and irregular. O2 sat 88% on high-flow oxygen. She's conscious but increasingly confused. Can you stabilize her until Dr. Patel arrives? That was the million-dollar question. Sarah had been trained in advanced cardiac life support, but managing a patient in cardiogenic shock without immediate physician backup was beyond what most nurses would attempt, especially one with only 3 months of experience. "I'll do everything I can," Sarah replied, knowing that everything might not be enough. She hung up and focused on Mrs. Morrison, who was trying to say something through the oxygen mask. Sarah leaned closer to hear the whispered words. "Tyler, if something happens to me, his grandmother in Portland, phone number in my purse." "Nothing is going to happen to you," Sarah said firmly. "But, Tyler, do you know your grandmother's phone number, just in case we need to call her to let her know you're both okay?" Tyler nodded and recited the number, which Sarah wrote on her notepad. She was trying to keep both patients calm while managing a medical crisis that was rapidly spiraling beyond her experience level. Mrs. Morrison's blood pressure dropped to 80/45. Sarah knew she was running out of time and options. She could start a dopamine drip to support the blood pressure, but that was typically a physician's order. She could prepare for emergency cardioversion if Mrs. Morrison went into a lethal rhythm, but, again, that required physician oversight. Marcus appeared at her shoulder, having finished with the truck driver. "How can I help?" "I need you to take over Tyler's care," Sarah said quickly. "Possible rib fractures, mild concussion. His mother is having a massive MI and going into shock." Marcus looked at the monitors and whistled low. "Where's the attending?" "Surgery and 40 minutes out respectively." Sarah was starting another 4-line in Mrs. Morrison's other arm, preparing to give fluids and, potentially vasopressor medications. "I'm going to have to manage this until help arrives." "Sarah," Marcus said quietly, "that's a lot of responsibility for someone with 3 months of experience." Sarah knew he was right, but she also knew that Mrs. Morrison didn't have the luxury of waiting for someone more experienced. "Then, it's a good thing I paid attention in nursing school." Mrs. Morrison's condition deteriorated further. Her blood pressure was barely registering, and she was becoming increasingly unresponsive. Sarah made the decision to start a dopamine infusion without waiting for a physician's order, calculating the dosage based on her ACLS training. "I'm starting dopamine at 5 micrograms per kilogram per minute," she announced to Marcus, who nodded and made a note in Tyler's chart while keeping one eye on what Sarah was doing. The dopamine began to work almost immediately, and Mrs. Morrison's blood pressure stabilized slightly. But Sarah knew this was only buying time. Mrs. Morrison needed emergency cardiac catheterization to open the blocked artery that was causing the heart attack. "Mrs. Morrison, can you hear me?" Sarah asked, checking the woman's pupils with her penlight. Mrs. Morrison's eyes fluttered open. "Tyler?" He's right here, and he's going to be fine. You're having a heart attack, and we're taking you for a procedure to fix it. But I need you to stay with me, okay? Tyler had tears streaming down his face as he watched his mother struggle. Sarah knew she was managing not just a medical emergency, but a family crisis that would affect this teenage boy for the rest of his life. Dr. Ahmed, one of the internal medicine residents, finally appeared in response to Sarah's repeated calls for assistance. He looked exhausted. The multi-vehicle accident had pulled medical staff from throughout the hospital. "What do we have?" he asked, looking at Mrs. Morrison's monitors. Sarah gave a rapid-fire report. 52-year-old female, anterior STEMI, cardiogenic shock. Started dopamine about 10 minutes ago, blood pressure responding but still low. Cath lab is activated but Dr. Patel won't be here for another 30 minutes. Dr. Ahmed nodded, reviewing the EKG tracings and vital signs. Good call on the dopamine. Let's add some heparin and get her on a nitroglycerin drip. And prepare for emergency intubation if her respiratory status deteriorates further. Sarah felt a wave of relief that someone with more authority had arrived, but she also felt proud that her decisions had been the right ones. She began preparing the additional medications while continuing to monitor Mrs. Morrison closely. "Tyler," Dr. Ahmed said, turning to the teenager, "your mother is very sick, but we're doing everything we can to help her. The procedure she needs will open up the blocked blood vessel in her heart." Tyler nodded, his young face showing a maturity beyond his years. "Will it work?" Dr. Ahmed chose his words carefully. "We have very good treatments for heart attacks now, especially when we catch them early like we did with your mother. But I want you to know that this is serious." Mrs. Morrison's hand moved weakly toward Tyler, and Sarah helped connect their hands across the gap between the two beds. "I love you, sweetheart," Mrs. Morrison whispered. "I love you too, Mom. You're going to be okay." Sarah said, "You're going to be okay." Sarah felt the weight of that promise, the faith both Tyler and his mother were placing in her abilities. She had been a nurse for less than 4 months, but, in this moment, she was everything standing between this family and tragedy. The cardiac catheterization team finally arrived, led by Dr. Patel, who had made the 40-minute drive in 25 minutes. He quickly assessed Mrs. Morrison's condition and nodded approvingly at the care she had received. "Excellent work," he told Sarah and Dr. Ahmed. "Let's get her to the cath lab immediately." As they prepared to transfer Mrs. Morrison to the cardiac catheterization laboratory, Sarah realized that she had just managed one of the most challenging cases of her career. But what she didn't know was that the real test was yet to come. In the cath lab, they would discover that Mrs. Morrison's case was far more complex than anyone had imagined, and the decisions Sarah had made in the emergency department would prove to be the difference between life and death. Tyler grabbed Sarah's hand as they wheeled his mother away. "Thank you for taking care of her. I could tell she felt safe with you." Sarah squeezed his hand gently. "That's what we're here for." But, as she watched Mrs. Morrison disappear through the doors to the cardiac catheterization lab, Sarah couldn't shake the feeling that the most challenging part of this night was still ahead of them. Sarah Martinez had been working the night shift at General Hospital for exactly 3 months and 14 days. She counted because every experienced nurse reminded her that she was still the new girl on the emergency ward. At 24 years old, with her nursing degree still feeling fresh in her hands, Sarah often felt like she was swimming upstream in a river of medical expertise that seemed to flow effortlessly around her. The clock on the emergency department wall showed 2:47 a.m. when the first ambulance sirens pierced the quiet Tuesday night. Sarah looked up from the patient chart she was organizing, her heart already beginning to pick up pace. Night shifts were supposed to be calmer, but General Hospital sat right off Interstate 95, and car accidents had a way of changing everything in an instant. Dr. Rebecca Chen, the attending physician, appeared at Sarah's elbow with the kind of focused energy that meant serious trouble was heading their way. "Multiple vehicle accident on the interstate," she said, her voice crisp and professional. "We're getting 3 ambulances. 2 critical, 1 stable. ETA 4 minutes." Sarah nodded, her hands already moving to prepare the trauma bays. She had been through emergency drills dozens of times during nursing school and her orientation period, but real emergencies still made her pulse quicken. The other nurses moved with practiced efficiency around her: Janet Williams, who had 22 years of emergency experience, and Marcus Thompson, who could start in 4-line faster than anyone Sarah had ever seen. The first ambulance backed up to the emergency entrance with its red and blue lights painting the walls in urgent colors. The paramedic team rolled out a stretcher carrying a middle-aged man whose face was pale beneath an oxygen mask. Blood stained his shirt, and his left arm hung at an unnatural angle. 53-year-old male, driver of the sedan, the lead paramedic called out as they wheeled him toward Trauma Bay 1. Possible internal bleeding, definite fracture to the left radius and ulna, vital stable but blood pressure dropping. Lost consciousness at the scene for approximately 2 minutes. Dr. Chen took charge immediately, with Janet assisting. Sarah found herself assigned to the stable patient, a teenager who had been a passenger in one of the vehicles. The boy sat on the examination table, holding his ribs and trying not to cry in front of his worried mother who had driven herself to the hospital. "What's your name?" Sarah asked gently as she approached with her stethoscope. "Tyler," the boy managed. "Tyler Morrison. My ribs hurt really bad, and my head feels weird." Sarah began her examination, checking Tyler's pupils for signs of concussion and carefully palpating his ribs for fractures. His mother, a woman in her 40s with tears streaming down her face, gripped Tyler's hand tightly. "Is he going to be okay?" she whispered. The other car came out of nowhere. Tyler was sleeping in the passenger seat when it happened. "We're going to take very good care of him," Sarah assured her, though she made mental notes about the tenderness she felt along Tyler's ribcage and the slight confusion in his responses to her questions. "Tyler, can you tell me what day it is?" The boy hesitated. "Tuesday? I think it's Tuesday. But I'm not sure about the date." Sarah continued her examination, documenting everything carefully. She had learned that in emergency medicine, the details that seemed small often turned out to be the most important. Tyler's confusion worried her, and the way he favored his left side suggested possible rib fractures. The second ambulance arrived with its own urgent symphony of sirens and radio chatter. This one carried the driver of the truck that had caused the accident, a man in his 30s who was conscious but had suffered significant injuries to his legs. The third ambulance brought an elderly woman who had been driving alone, suffering from shock but with only minor injuries. The emergency department transformed into a controlled chaos of medical activity. Every trauma bay filled, and Sarah found herself moving between patients as Dr. Chen coordinated care for the most critical cases. The man from the first ambulance required immediate surgery, and the truck driver needed extensive orthopedic work. Sarah was drawing blood from Tyler when she noticed his mother's breathing had become rapid and shallow. The woman's face had gone pale, and she was gripping the side rail of the examination table with white knuckles. "Mrs. Morrison?" Sarah asked, setting down the blood sample. "Are you feeling all right?" I can't." The woman gasped. "I can't breathe properly. My chest feels tight." Sarah immediately recognized the signs of a panic attack, but she also knew that chest pain in a middle-aged woman could indicate something much more serious. She pressed the call button for additional help while keeping her voice calm and reassuring. "Mrs. Morrison, I want you to try to breathe slowly with me. In through your nose, out through your mouth." Sarah demonstrated the breathing technique while simultaneously reaching for a pulse oximeter to check the woman's oxygen levels. Tyler, despite his own injuries and confusion, reached out to take his mother's other hand. "Mom, it's okay. I'm going to be fine." But Mrs. Morrison's condition wasn't improving. Her pulse was rapid and irregular, and she was becoming increasingly distressed. Sarah made a quick decision and called out to Marcus, who was helping with the truck driver. "I need someone to look at Mrs. Morrison in bed 3. Possible cardiac event." The emergency department was already operating at capacity, with all the medical staff focused on the trauma patients. Dr. Chen was in surgery prep with the most critical case, and the other attending physician was dealing with the truck driver's complex leg injuries. Sarah found herself in a position that every new nurse both fears and prepares for. She was the most available medical professional to handle a potentially life-threatening situation. Mrs. Morrison's breathing had become even more labored, and her lips were showing a slight blue tinge. "Tyler, I need you to press this call button if your pain gets worse," Sarah told the teenager, then turned her full attention to his mother. "Mrs. Morrison, I'm going to put some oxygen on you and get an EKG machine." The woman nodded weakly, her eyes wide with fear. Sarah moved quickly but calmly, knowing that her demeanor would affect both patients. She had been trained for situations like this, but training felt different when a real person's life might depend on her decisions. As she attached the oxygen mask and wheeled over the EKG machine, Sarah's mind raced through the differential diagnoses she had learned in nursing school. Panic attack, heart attack, pulmonary embolism, all possibilities that required different treatments and different levels of urgency. The EKG leads went on smoothly, and Sarah watched as the machine began to trace Mrs. Morrison's heart rhythm. What she saw on the screen made her blood run cold. The rhythm was irregular, with concerning changes that suggested something far more serious than a panic attack. Mrs. Morrison was having a heart attack. Sarah's hands moved automatically to start another 4-line while her mind calculated medications and dosages. She had assisted with cardiac emergencies before, but never as the primary nurse with limited backup available. The weight of responsibility settled on her shoulders as she reached for the emergency phone to call for immediate physician assistance. But even as she dialed, Sarah knew that in a hospital already stretched to its limits by the multi-vehicle accident, help might not arrive in time. Mrs. Morrison's condition was deteriorating quickly, and Tyler was watching everything with growing terror in his young eyes. The clock on the wall showed 3:15 a.m. In less than half an hour, Sarah's quiet night shift had become a test of everything she had learned about nursing, about emergency medicine, and about staying calm under pressure. What she didn't know was that the next 13 minutes would define not just Mrs. Morrison's survival, but Sarah's entire career. Mrs. Morrison's hand found Sarah's wrist, gripping it with surprising strength for someone in cardiac distress. "Please don't let me die," she whispered through the oxygen mask. "Tyler needs me. His father died 2 years ago. I'm all he has." Sarah looked into the woman's eyes and made a promise that would either save a life or haunt her forever. "I've got you, Mrs. Morrison. You're not going anywhere." The emergency department continued its urgent symphony around them, but in that moment, Sarah's world narrowed to one patient, one family, and 13 minutes that would change everything.